Okay, so boleh start ke? Saya dah tengok dah slides. Saya tak sempat nak komen lah sebab saya rasa, tapi nampak okey je. Okay, boleh start. Kejap, you guys year 3 ke year 5 lah? Year 5 kan?
Year 5 Dr.
Okay, okay. Continue.
Okay. Semua nampak tak slide saya?
Yes.
Okay. Bismillahirrahmanirrahim. So I will be the first presenter for today's seminar. Okay. Okay, Bismillahirrahmanirrahim. So I will start this presentation. I will talk about the child with altered consciousness. My name is Niswa and our supervisor will be Dr Alwi lah. Okay. So first of all, for this topic, we need to know several definition that related to this topic or to the altered consciousness. So what is mean by the consciousness? Okay. So what's mean by consciousness is the awareness of self and also environment, meaning that the patient need to aware of themselves and also the environment surrounding him or her, which is the place and time. And then what is mean by the arousal? So the arousal is mean that it is a system that initiate and maintains the consciousness. That's why to describe a patient, we cannot say the patient is aroused or not. So we need to say the patient is conscious or not aroused. Okay, so the arousal is not to describe a patient. So there is several spectrum of impaired consciousness, from the drowsiness up to the delirium and also brain death. So what is mean by drowsiness? Drowsiness is resembles the normal sleepiness, and it is fairly easily aroused to the normal wakefulness, and the patient can fall asleep again when we left them alone. And that's mean by drowsiness. So what is mean by lethargy? Lethargy means a difficulty in maintaining the arousal state. And obtended is quite what we call severe or much severe than lethargy. It is a decreased arousal state but still respond to the stimuli. It's quite the same lah between lethargy and also obtended. And then what is mean by stupor? Stupor is a loss of consciousness, and the patient will only respond to this pain stimulus only. And coma, there is two, coma and deep coma. So coma means respond semi-purposefully in consider to light. But in deep coma, the patient will not have any response to any stimuli and no reflex at the present. And then what is meant by syncope? Syncope is the abrupt, it's sudden loss of consciousness, and it is episodic loss of consciousness. And brain death is a coma plus with apnea and absence of the brainstem reflex. And lastly, the delirium. What is meant by delirium is the disturbance of the consciousness with low focus duration and also shift of the attention. So this is from the drowsiness up to the delirium. You can see my cursor, right? Kita nampak tak?
Nampak.
The drowsiness up to delirium, it is actually a spectrum of impaired consciousness between the full arousal and the complete unresponsiveness. Okay, the differences is between either the patient is responded to the stimuli or not. Okay, this is the definition. And then next, okay, what is the physiology behind the how we maintain our conscious level? Is that there is an ARAS, which is ascending reticular activating system. This ARAS is actually a neuronal circuit connecting from the part of the brain to the cerebral cortex, thalamus, hypothalamus, cerebellum, and to the various sensory neuron. Basically, the ARAS system actually located at the base of our membrane. And then how this ARAS function is that what is it, arousal, and then arousal is the intact communication between the ascending reticular activity center ARAS to the targeted site. Just now I said that the arousal is a system, right? The system. So this is intact communication between the ARAS up to the targeted site. And what is the consciousness and awareness? Or awareness is actually a widely distributed network between the cortical and the subcortical structures in the brain. So this consciousness can be diminished or abolished by the dysfunction within the brainstem, impairment of the both cerebral hemisphere, or the insult that globally that depress the neuronal activity. And any disruption along the way, along the communication, will impact the consciousness level of the patient. And the acute changes in the consciousness can be have very degree from the lethargy up to confusion and up to the deep coma just now, like I said before. Okay, it's a spectrum of the impact consciousness. Okay, this is physiology. Next, there is several etiology that we need to consider if the patient come to us with impact consciousness. This etiology I take from the PITS protocol. However, there is a very long list of the causes as well in the Nelson Ascension in Pediatric 7th edition. So you can look after this. But this is, I think this is the what we need to think of when the patient come to us with impact consciousness. So the first one would be the CNS infection, such as meningitis, encephalitis, any brain abscess. We need also to consider any trauma to the brain, and any vasculitis due to the autoimmune disease, any acute poisoning of the drugs such as antihistamine or anticonvulsion, and then any metabolic diseases that we need to consider such as diabetic ketoacidosis and also hyperammonemia. And also non-accidental injury we need to consider, especially in child, right? So we need always to consider these causes, non-accidental injury. And then post-convulsive state, hypertensive crisis, ADEM or ANEC, which is acute disseminated encephalomyelitis or acute necrotizing encephalopathy. And this is an autoimmune disease lah, immune-mediated disease. Immune-mediated disease. So we need also to consider stroke or cerebral venous thrombosis as well as the acute hydrocephalus. And another way we can classify the etiology is based on the ABCD, like Dr. Teach us before, right? Vitamin C, D, E, which is vascular, V for vascular, I for infection, T for trauma, A for autoimmune, M for metabolic, I for idiopathic or iatrogenic, N for neoplasia, C congenital, degenerative, as well as E for endocrine. After this, I will edit a little bit my slide. That's the way how we want to memorize. Actually, not for this topic lah, for all topic. So we can memorize the differential diagnosis according to the vitamin C, D, E. Okay, that's all for the etiology. And then how actually we want to approach the patient or child with acute loss of consciousness. First, we need to do from this. I take from this approach. I take from the PITS protocol. So first, we need to do the initial assessment, and then we need to assess the GCS of the patient and look for the common causes and find the etiology, and then do several investigation, and then we need to manage the patient and see the outcome. What happened to the patient. So first, we go to the initial assessment. So what initial assessment that we need to do when the patient, meaning that when the patient presented to us with acute loss of consciousness, so we need to do, for the first we need to do is the ABCDE. So what is ABCDD? Okay, ABCD, A for airway, we need to secure airway and we need to secure the airway and consider the endotracheal intubation if the patient in severe state. And then the breathing, we need to secure that we need to give oxygenation, and if needed, we need to give the ventilation. So why actually this airway and breathing is important? We need to secure first because Nelson mentioned that the main causes of the morbidity in patient with depressed consciousness is hypoxia. So this hypoxia can lead to the poor prognosis of the patient. That's why first thing first, we need to secure the airway and breathing of the patient as well as circulation. And then check for the stroke states of the patient, whether the patient in hypoglycemic state or not. Because somehow if the causes is the hypoglycemia, is actually a rapidly treatable causes of the altered mental state. So if we know earlier the causes, the cause which is hypoglycemia, so we can treat the patient earlier. So this is cited from the PITS protocol lah. So and make sure to one stable monitor the heart rate, BP, respiratory rate, SpO2 as well as the urine output. So that's for the initial assessment. And then we go to the how we want to assess the GCS of the patient. This is the GCS of for the child and also infant. So basically for the child, it's quite the same with adult. So we can look here. The eye still same, spontaneous to speech to pain and non-response. Verbal is quite the same, right? However, for the infant, it different in the verbal response, whereby if the patient can coos and babbles, we can consider patient have 5, score of 5. If the patient is irritable to cries, the score is 4, and cries to pain 3, moans to pain 2, and no response is 1. And for the motor response as well, actually dia macam quite the same jugalah, tapi macam awal-awal ni, the first thing is the patient, if the patient can move spontaneously and purposeful, we consider 6. If withdraw to the touch is 5, and if the child is withdraw to the response in pain is 4, and there is a decorticate and decerebrate 3 and 2, and no response is 1. So if the patient is intubated or unconscious or pre-verbal, the most important part of this skill is the motor response. Kan? Because the patient is tak boleh cakap kan. So motor response should be carefully evaluated at this moment of time. So this is the level. If the GCS is 12 and more, so we need to monitor the GCS of the patient hourly. If the GCS of the patient is less than 12, meaning 11 and below, so we need to monitor the GCS 30 minutes, every 30 minutes until the GCS is improved. Okay kan cakap ni? Okay, so this is for the GCS. So when we need to consider the endotracheal intubation during the initial assessment just now, right? So this is the indication of the endotracheal intubation in patient with altered consciousness. So so we need to consider if the airway is obstructed, if not supported by any device, and then the airway also compromised by vomiting. 1, 2, 3, 4. There is 7 indication. 3, the respiratory rate is too low despite giving adequate ventilation to the patient. 4, the SpO2 remain less than 92% despite giving high flow oxygen and also airway opening maneuvers. And 5, there is sign of shock. Even though we give enough or more fluid resuscitation, there is a still presence of the sign of shock. And then signs of exertion. And lastly, the GCS is 8, less than 8, meaning 7 and below, and it is keep deteriorating. So that's why we need to monitor the GCS level of the patient just now, right? If 12 and more, hourly. If less than 12, 30 minutes until improve. Every 30 minutes until improve. Okay, this is the indication. Okay, next we go to the common causes and find the etiology why this patient had altered mental status. So you can remember it by this acronym triple SIP, which is triple S means sepsis, shock, seizure. IP is the intracranial pressure. So but the first thing first, we need to think if the patient comes with altered mental state, is that the raise in intracranial pressure. Why? Because this is a medical emergency. So that's why we need to find the sign of the increased intracranial pressure first in patient with altered mental state. So what is the sign of the raised ICP? First, clinically has papular edema. We say it as we see the patient has raised in intracranial pressure, or any two of the following, which is DCS is less than 8 or deteriorating, and there is unreactive or unequal pupils, and there is abnormal Doll's eyes reflex. There is presence of decorticate or decerebrate posturing, and there is abnormal breathing such as Chinese stokes or apneustic breathing. So this is a medical emergency. We need to quickly manage the patient. Okay. Okay, so this is then decided from the Google lah. So then there is a normal. This is the normal respiration. The graph for normal respiration. If you can look here, the ataxic respiration or biased respiration, there is hyperapnea, and with the it is actually a periodic breathing of hyperapnea and apnea. Okay, you can see like the graph here. There is a periodic breathing of hyperapnea, apnea, hyperapnea, apnea, hyperapnea. Okay, this is the biased respiration. What is this Chinese Stokes respiration? It's also a periodic breathing, but this periodic breathing of the gradual hyperapnea or hyperapnea with apnea. Just now for bias is hyperapnea, right? So for this Chinese Stoke is actually a hyperapnea and hyperapnea with apnea as well. And what is Kussmaul breathing? Is continuous hyperapnea. This is the causes of the different type of the breathing. Okay. Okay, this is the same. Okay, so what is Doll's eyes reflex? Is those. Okay, how we want to do Doll's eyes reflex is actually we we hold the eye with our thumb and also our index finger, and then we turn the patient's face side by side. So how we want to interpret, if positive, meaning that the eye is moving in the opposite direction of the head movement, is indicating an intact brainstem. Ni macam ni lah, kira side by side, the eye is moving to the other side. Macam kalau kita gerak kepala at the left, the eye will move to the right, and vice versa. If negative, meaning that the eye is moving toward the same direction of the head. Kita pusing ke kiri, the mata gerak ke kiri, it means that there is a negative Doll's eyes reflex, meaning that the pathway is interrupted. Okay. So this is the posturing, decorticate and decerebrate. So this now is the increase in ICP, right? So we need to consider the sepsis, shock, and also seizure. So sepsis is you already learned before in previous seminar. Okay, so sepsis is any suspected or proven infection with any two of these clinical signs. We need to consider sepsis in this patient. So if there is the hypo or hyperthermia, if there is any inappropriate tachycardia or tachypnea, altered mental state, as well as any reduced peripheral perfusion or prolonged CRT, and then if shock, there is a presence of shock sign lah. Okay, and then if there is presence of seizure, so the etiology is either raised in intracranial pressure, sepsis, shock, or seizure. So what can cause all these causes? What is the etiology behind it? Okay, so we need to take a full history and do examination to the patient. So first, history, we must know the age of the patient, and then the onset of the symptom. Either it's sudden or abrupt, or it is gradual, because it different onset had different causes, right? So as any associated symptoms such as infection, symptom of increased ICP, electrolyte imbalance, fitting, trauma, and also tumor. You can read here. So infection, as usual, fever, rash, any manager symptoms of history of traveling. So for symptom of increased ICP, there is presence of headache, nausea, vomiting, blurry of vision. inconsolable crying, and also irritability. If there is a symptom of electrolyte imbalance, the patient will present with weakness, GI loss, or any poor oral intake, fitting, and trauma, so on. Okay, so past medical history. If the patient had any underlying illnesses before, such as renal problem or endocrine disorder, or previous episode of inborn error metabolism, and then drug history, any ingestion of drugs or toxin, or the availability of the substance, such as anticonvulsant and also antihistamine, that can cause the altered mental state of the patient. And then family history, any family history of malignancy or consanguinity to suggest IEM. And then social history. And then we go to the physical examination. So first, general examination. First we need to take the vital sign of patient to see the temperature and heart rate, the respiratory rate, and also blood pressure. Because this is, we can actually rule out the sepsis and also the shock, right? Sepsis and shock in patient. And then the appearance of the patient. Either patient is ill looking, or any rashes that indicate the infection, jaundice that we can the presence in the hepatic encephalopathy. If the patient is sick, or sign of dehydration, or any abnormal posture, such as decorticate and cerebrate just now, or fitting. And then don't forget to look for any sign of any abuse in the patients. Okay, to rule out any non-accidental injury. Okay, so for head examination and the appearance of the patient, disproportionately large or dilated veins, and the head of circumference to look for hydrocephalus, and any bulge or tense fontanelle that indicate increase in ICP. And then eye examination, we know want to look for the, just now, right, the papillary size or response to the light, as well as papillary edema in telescopy. So any sun, setting eye that presence in the hydrocephalus, and we need to do the CNS examination to look for the posture, assess the level of consciousness, GCS just now, but we did the GCS earlier, right? So the Kernick and Brudzinski sign that indicate meningitis. And then we need to do fundoscopy because first to look for the signs of increased ICP. If there is presence of papillary edema, only pun kita dah cakap there is risk in intracranial pressure, and any retinal hemorrhage to look in non-accidental injury. Okay, this is fundoscopy finding. If we kalau tengok sini, there is a normal optic disc, right? We can see the sharp disc of the margin. The gambar yang bawah ni, gambar bawah kanan. This is a sharp disc of the margin, but in the papillary edema, there is a blurred disc of margin. Kita tengok, lepas tu there is a macam kita panggil optic disc swelling as well. Macam keliling tu indicate the edema of the optic disc. This is the sign of the increased intracranial pressure, and it is a medical emergency. Okay. Okay. After we have looked for the causes and also find the etiology behind it, so we need to investigate further. So what investigation we need to do is the first blood investigation, which is first full blood count to look for any anemia or any sign of infection, renal profile to look for any electrolyte imbalance, blood CNS to look for the presence of infection as well, and liver function test, serum ammonia, as well as urinalysis. And after that, we need to do neuroimaging. So neuroimaging is CT brain and also MRI. So in PITS protocol mentioned that we need to do urgent neuroimaging for all children with high ACP when the child is stable, and we need to consider MRI brain within 48 hours if possible. If the investigation if the MRI is not done at presentation, when the diagnosis is still uncertain. But first thing first, we need to do CT brain in this patient once the patient is stable. Okay, and then we can also consider any invasive investigation like lumbar puncture to look for CFS analysis, but we must rule out the increase in intracranial pressure first, because it can cause herniation if the patient had increased intracranial pressure. So better we do the imaging first lah, for CT brain first before we want to consider the lumbar puncture. And then others investigation that we can do is like EEG, IEM screening, PFMP, malaria parasite tu, blood film for malaria and malarial parasite, toxicology as well as vasculitis screen if the diagnosis is still uncertain lah, from this blood and also imaging. Okay, and then after investigate, now we want to manage the patient. So the goals of managing patient with altered consciousness is to stabilize the patient as well as to treat the underlying causes. So here is the management of this ICP, because it is actually the medical emergency lah, in altered in child and also in patient, in adult as well lah sebenarnya. So first, what we need to do is the nursing. So we need to position the head in the midline as well as elevate head of the bed up to 15 to 30 degrees Celsius. 30 degree, because actually why we elevate the head is that we want to increase the venous return, and then cause the distribution of the CSF to the subarachnoid, so and then we can apa kita panggil macam distribute the pressure of the distribute the pressure. However, if if we elevate the head of the patient, actually we cause the increase in the cerebral perfusion pressure. Tapi kita dibenarkan untuk raise the head as long as the CCP remain in appropriate level. Kita nak reduce the ICP, but at the same time we want to maintain the CCP of the patient. So kalau in some articles saying that we need to elevate the head up to 45 degree but not more than 45 degree, because if more than that we cause in reduction in the CCP, cerebral perfusion pressure. Okay, and then avoid the unnecessary suction or procedure, avoid hyper or hypothermia, as well as avoid any intrajugular central venous line to prevent the stress to the patient. And then ventilation, we need to give the adequate sedation and also analgesia and maintain the good oxygenation. Why we need to ventilate the patient? Because when we ventilate the patient, actually we produce a rapid but transient reduction in the intracranial pressure by cerebral vasoconstriction, and thus causing the low blood volume, and then causing the reduce in the intracranial pressure. Okay, and then we need to keep the patient well hydrated, and then by giving the usually we give the normal saline to the patient. And then we avoid the hypoosmolar fluid as well as the plain dextrose solution. Why? Because we want, when we give good hydration to the patient, actually we can produce osmotic shift of the fluid from the brain to the plasma. This reduce in the intracranial pressure. Okay. And then we need, we also need to maintain the cerebral blood flow by keep the CCP above 50 millimeter mercury, like I said before lah kan. Okay, so how to measure the CTP is by minus MAP minus intracranial pressure. So how we want to measure the intracranial pressure actually? So the gold standard is actually by ventriculostomy. It's actually an invasive procedure lah that we need to poke into the skull of the patient to measure the to measure the intracranial pressure. However, we also can do a spinal tap by measuring the CSF pressure. But the gold standard is actually the ventriculostomy just now lah. But it's actually very invasive, so actually we need to avoid juga lah in patient with altered mental state to avoid more stress to the patient. We need to remember increased ICP is a medical emergency. We need to treat it urgently to prevent herniation. Although the acute treatment of the raised ICP is actually transient, but we need to treat it urgently to prevent further complication. And the timely intervention can reverse the herniation. Kalau kita delay, lagilah it can cause irreversible of the herniation tu. So we need to treat them urgently. The next is hypoosmolar. Like I said before, we can consider the IV mannitol and also hypertonic. And then the surgical decompression if the medical measures is failed. So we need to consider any surgical intervention to the patient. However, we need to do the medical measures first lah before we want to consider the surgery. Okay. Okay, that's all for the management of the increase in intracranial pressure. So, but the ultimate management for the increase in intracranial pressure is to treat the underlying causes. So, so we need to find why actually the patient had increase in intracranial pressure. Okay, so the outcome is depends on the underlying causes. 1/3 will die, 1/3 will recover with deficit, and 1/3 will recover completely. It actually depends on the underlying causes. And then this is from Nelson. Usually intoxication of any drugs carries good prognosis with early intervention, but hypoxia carries poor prognosis. That's why in early assessment just now, we need to maintain the airway and breathing of the patient, because we don't want the patient goes into hypoxic state, because the hypoxia carries a poor prognosis in patient. So other factors can be duration of the coma as well as the age of the patient. Usually children have better outcomes than adults, and many survivors from the prolonged coma left in persistent vegetative state or with severe neuropsychiatric disability. Itulah. This is prognosis of the patient. Okay, this is my references. I take from the PITS protocol, National Essential, Tele Ocon, as well as from up to date. Okay, I think that's all from me. Okay, any question?
Good. Very good presentation. So any question, guys?
Assalamualaikum. My name is Muhammad Jazli. I'd like to ask for regarding the vasculitis screen, is it like specific vasculitis? Is it by itself vasculitis screen, or it is tailored to the different differentials such as SLE, we do complement, or
Yes.
it depends
Betul,
on.
Zaz. Depends on the etiology lah. Macam kalau if the patient is female, so we need to consider any SLE kan. So if from the blood investigation and also the neuroimaging we cannot see any causes we can't find any causes, so we need to consider the autoimmune disease. So the most common SLE lah kalau untuk female kan.
Okay, thank you.
Okay.
Good. Any more questions? So basically this is very important topic, altered conscious level. So basically you have to understand, you have to know how to assess conscious level. Okay, we usually use GCS, but actually GCS is mainly for trauma lah actually. For non-trauma, for medical, it is sufficient just to assess using you know the definition that you've used earlier. like whether patient stupor, alert, macam AVPU kan, tahu kan AVPU kan, the alert, verbal, pain dengan consciousness. That is sufficient. However, most of the time we use GCS. So whenever you see a patient, you have to determine the level of consciousness, and you have to present because it's part of the ABCD kan. You know, you've got the initial assessment is always airway, breathing, circulation. Disability is your conscious level. So you have to determine patient ni obtunded ke, comatose ke, patient ni alert, unconscious. That's very important. And then secondly, if this is something chronic, then it may not be important lah. Tapi if this is very important in acute setting. So patient presented with acute altered behavior or acute altered conscious level, then this is a medical emergency. Especially you have to detect things that is reversible lah. When you talk about cerebral, especially cerebral edema kan, edema that is irreversible, especially things like intoxication. The most important and the most important step when you see a patient with altered behavior, first is make sure the airway competent, ABC, and then the disability. The least thing you have to do is check the sugar. Okay, this is very reversible, because a lot of time, especially in young children, a lot of few factors, maybe sepsis, or maybe they got metabolic problem, and they presented with altered behavior, and it turns out to be hypoglycemia, okay, or hyperglycemia. You rightly mentioned DKA kan, DKA, because DKA can present with vague symptoms. Yeah, I've met babies, patient who came with abdominal pain, fever, abdominal pain, and then intubated. Came treated as AGE lah, macam-macam dia pelik-pelik. And then suddenly when you check BSL, it's actually 20-30 BSL. The sugar is 20-30, and it turns out to be DKA. Because if you didn't treat early, they will develop hyponatremia, which actually leads to cerebral edema. Okay, and then besides that, things that irreversible macam electrolyte kan. Electrolyte you have to check. What else? Yang main lah. And then diagnosis, the best method is actually fundoscope. Okay, that's the quickest and simplest. It's not simple. If you got the technique, then it will be simple lah. But if you don't have the technique, try to get someone who can do fundoscope. Okay, for example, if you happen to be in the hospital during on call, and then suddenly got a patient presented with altered behavior, or patient in ward presented with altered behavior, then you need to have a very good fundoscope skill lah. You need to be able to assess the fundus accurately, and get someone who can assess the fundus. Because to arrange CT scan, it may take time. Okay, it may take time. Kalau you dekat district lagi lah, you kena tahu about fundoscope. Okay, pasal apa again? Okay, and then so let's talk about the cerebral edema. So basically, cerebral edema, there's a lot of type of cerebral edema. In order to determine you have to do MRI lah to determine what type of cerebral edema. You've got vasogenic cerebral edema, you've got hydrostatic cerebral edema. There's a lot of type. This type can give you clues lah, actually what is the causes. But usually, clinically, it's not that important lah. Acute management is not that important, because most cerebral edema, we treat it equally. The main treatment is, you mentioned, the conservative treatment by positioning, make sure the head is straight, the neck is straight, elevate the bed a bit, hyperventilation. Even though hyperventilation, actually in adult, there's not much evidence in it. Nowadays we are moving away from it. But acutely, it's good. Acutely, it is advisable lah to hyperventilate, especially patient already intubated kan, on ventilation. And you also have to understand, in order to understand the effect of increase of cerebral edema, you have to understand the Monroe-Kenley doctrine. Tahu kan? Anyone ever heard about Monroe-Kenley doctrine? Okay, siapa? Aklan ke? Okay, what is Monroe-Kenley? Macam it's break. Um, hmm, hmm. Okay, so that's good. That's good. So basically, your skull ni is a closed compartment tau. It's a closed compartment. It's a fixed compartment. I mean, we are talking about all the children now. Once your fontanelle fuse, then it's a fixed closed compartment. Therefore, in the content of your skull consists of your tissue kan, brain tissue, parenchyma, and then your CSF and blood. Okay, because it's closed system, any increase in the volume of each of the components will compromise the other components. Okay, so if you got edematous brain tissue, kan, for whatever reason, edematous brain tissue, this will actually compromise the CSF and also the blood. What we worry the most is actually the blood, because once the brain is edematous, it will reduce the blood, it will compromise the blood supply, and it will lead to ischemic hypoxic insult, and then ischemia, and finally necrosis of the brain lah, yang paling kita takut kan. That's why we need to treat the cerebral edema quickly. Okay, I've seen patient. Okay, I actually just before I came here, I think back in May ke June, I think June kot, before I came here. We've intubated. I've intubated a child lah. This is myelomeningocele child, spinal bifida, never had seizure, no epilepsy. And then admitted. I mean, came to hospital because of meningitis. We think it's meningitis. And then suddenly patient just collapsed. So we intubate this patient. It's very quick. And then after a while, noted patient tachycardic. Okay, the only sign is tachycardia. And then I've attended the patient. Looks, there's an unequal pupil. The doll eye reflex were abnormal. So we think this is a cerebral edema lah. So I give hyposmolar. We give actually hypotonic saline, 3% saline, and then it settled, it resolved. But then I pass over lah. The next day, same thing occurred, but this time is I mean it's irreversible, and subsequently the patient died lah. Patient died most likely because of conning lah. Tapi so what I want to stress here is first in managing cerebral edema kan, you've got acute management, and after you done with your acute management resuscitation, you have to determine the causes, and you have to treat the underlying causes, because if not, it will reoccur, and then finally it progress to at the end conning lah. So that's why the first step is actually to recognize, and then you have to resuscitate, reverse it, and then you have to treat the underlying causes. Okay, especially irreversible causes such as metabolic causes. Okay, besides that, there's one of the common cause in pediatric, one of the common cause of cerebral edema. One is sepsis. Second is sepsis, including encephalopathy, encephalitis, and also meningitis. And then second is metabolic causes. This include electrolyte, sugar. You've correctly mentioned about hyperammonemia kan, this IEM. And then the other thing is seizure. Okay, seizure. Because seizure, especially in babies kan, in neonates, they don't have all this jerky movement now, seizure. They're usually very subtle. Okay, how seizures presented in neonates? Siapa boleh jawab? Anis lah, Anis Wardati. Okay. How baby presented with seizure? How seizure in babies usually described as?
Rolling eyeball.
Okay, actually rolling eyeball is very rare lah in neonates. They may have lateralization, but usually it's more focal. Okay, in neonates it's more focal. Okay, especially young neonates are less than 1 month kan. A lot of time they're presented with lip smacking, hiccup. Hiccup is a sign of seizure lah. Especially if the baby already sedated and ventilated, you don't expect them to hiccup. Okay, but if they hiccup, even older children one, if they already ventilated and then they hiccup, then that's a sign. Most likely, patient is actually having seizure. Okay. And then the other sign is autonomic changes. For example, sudden disproportionate tachycardia or bradycardia, BP, increased BP, low BP. This autonomic fever kan. Fever sometimes suddenly patient spike temperature, all these active parameter negative, and then got bradycardia. So autonomic changes can be subtle sign of seizure lah. So you have to abort. Okay, it's good to have EEG lah, ambulatory EEG. Tapi kalau tak, then you have to use your clinical judgment. Okay, and then lastly, I think the other important thing is the concept. I mean the maintaining of blood pressure. Okay, and because you've mentioned cerebral perfusion equals to MAP minus ICP kan. So basically when you've got cerebral edema, you've got increase in ICP. So when you've got increase in ICP, okay, what happened to your CPP? Okay, you know the equation kan? CPP equals to MAP minus ICP kan? Assuming your MAP is same, okay, unless patient shock lah. Okay, patient not in shock, so MAP is the same. So if you increase ICP, what happened to your CPP? Reduce kan? Okay. Okay, so this is what we want to prevent, the reduction in CPP. That is the main aim actually. The main aim is actually to maintain the perfusion. So in order to maintain the perfusion, you have to increase the MAP. You have to increase the MAP and make sure the blood pressure is normal. Okay, actually we usually aim towards the higher normal lah, higher normal. Not to the extent of hypertension, but we want it to be higher normal. The MAP, that's why you've mentioned in your slides, do not use high PEP kan, high PEP kan. Sebab, do you understand what is PEP ke? This what PEP yang you mentioned tu apa? What is PEP?
The pressure to maintain the alveolar from collapse during expiration.
PEP kan? PEP is stand for positive and expiratory pressure. So this is a pressure, we generate PEP all the time. A normal PEP is about 5 lah, 4 to 5. So in our physiologically, we have our physiological PEP, where this is to maintain the alveolar lah. At the end of expiratory, we maintain it partially pattern, partially inflated. Okay. So when you artificially ventilate a child or anyone, you have to determine the PEP. Okay, you have to set the PEP. Problem is, if you set the PEP too high, okay, what happen is you'll get increase in intrathoracic pressure. Okay, PEP represent your intrathoracic pressure lah, in general. So if you have high intrathoracic pressure, what will happen? What will happen to your venous return?
Reduce.
So you can reduce venous return kan. So reduce venous return, what will it reflects? It will reduce your BP lah kan. So BP will reduce. So reduce your BP, reduce your MAP, so it will reduce your CPP. That's why usually the strategy is use low PEP, because the aim is actually to maintain the high MAP. And you've mentioned about hyperventilation kan. because low CO2 will actually constrict the vessel, kan, constrict the veins, constrict the venous lah. So by constricting the venous, you reduce the intracerebral pressure. Okay, without affecting the perfusion lah, because you are reducing the venous. You are constricting the venous, not the artery. So macam tu lah. So that's a physiology lah. That's a physiology. Okay, and then I think that's all kot. Okay, and do you understand what is the how hypertonic solution? Okay, what is the difference between osmolality and tonicity? Okay, saya Nadia Ardila. Okay. What contributes to osmolality? Because this is because you are 5th year, so I expect you to understand this basic physiology lah, because you need to know how to calculate the osmolality, how to calculate the tonicity, I mean, this is a very important physiological concept, because a lot of housemen and a lot of doctors, they don't know this. I mean, so if you don't know this, then you will mismanage patient, especially patient with brain problem, with lung problems. This, you have to consider this a lot of time in your management lah. In your needs, okay, this patient with problem with poor GFR, kan, poor renal clearance, with metabolic problem. So this is very important. So Nadia, what contribute your osmolality?
Osmolality is contributed by the amount of solute in our blood, in the intravascular solute.
Okay, what are the solute? What are the solute that is important?
The metabolite, the sodium and the potassium.
Okay.
And then we have the chloride, the bicarbonates, or the ionic.
Okay, what is the formula to measure osmolality? What is the formula to measure osmolality, serum osmolality? I presume you dah belajar HHS, kan? In medical, internal medicine, you belajar HHS, kan? Okay, so
See the tuna glue, doctor?
apa dia?
Tuna glue, 2 sodium plus glucose plus urea.
Okay, good. So you understand, kan? Things that contribute to your osmolality is glucose, urea, and sodium. The main, you've got effective osmolality, you got osmolality lah. So occasionally we add up potassium, because potassium is very low lah. Intravascular potassium is very low. So it's basically 2 sodium, 2 sodium plus glucose and also urea, kan? So what happened? Okay, if you give a patient with cerebral edema, you give dextrose containing solution. Maksudnya you bagi patient ni required fluid, dehydrated, ataupun required fluid resuscitation. So you bagi dextrose, D10 for example, without sodium. What will happen?
We will increase the osmolality, increase the concentration of the blood, causing more dehydration.
Okay. Why osmolality is important? See, why osmolality is important? Because you want to give in cerebral edema, you want to give high osmolar fluid in order to because you want to use osmosis to actually to extract the water from the brain parenchyma into the vessel. Faham tak? So you give, contoh you bagi nama mulut tu. Okay, you bagi contoh you bagi 3% saline lah, kan? You bagi 3% saline, kan? You bagi 3% saline. So you are giving intravascular, kan? So bila this high osmolality fluid dia pergi dekat brain, dia akan by using osmosis, the fluid, intracerebral fluid, in the intraparenchymal fluid will actually shifted into intravascular. That's your aim. Tapi what happen if you give dextrose containing fluid? Dextrose ni dia masuk je dalam blood, all the tissue will use it, will consume the dextrose. So what happen? What left? Kalau you bagi D10 kan, masuk dalam badan, within few minutes kan, what left in your vessel is just water. Faham tak? Because the dextrose will be consumed. So just water. So what happen? The water, because from using via osmosis, the water intravascular will actually enter the parenchyma. So it will worsen your cerebral edema. Faham tak? So never give dextrose alone. You need to have sodium. You need to give isotonic solution lah. Because sodium is mainly intravascular, so it will attract all the fluids, extract all the fluid from the parenchyma into the vessel. Okay, faham kan? So that's the concept lah. And then you also need to understand the concept of isotonicity and so on lah. Okay, tapi yang tu not related to cerebral edema. Okay, ada any questions?
Sorry to disturb, but I would like to ask. I read somewhere that when we have high glucose, it can cause hyponatremia.
Yes.
But the term used is pseudo hyponatremia. Is it the same as the typical hyponatremia, or why is it called like pseudo hyponatremia?
Okay, actually there's a lot of theory behind it, but I believe the main physiological concept is actually like what I explained just now. If you've got too high glucose, okay, if you've got too high glucose, for example in patient DKA kan, you've got a lot of glucose in your body kan, a lot of glucose in your intravascular, because this glucose cannot be used in your metabolism lah, because you don't have insulin to push glucose into the cellular kan. So glucose remain in the vascular, intravascular. So what happen is, if you start insulin, okay, all this sugar, if you give a rapid insulin kan, that's why you can taper down or you can taper up the insulin slowly. Okay, you cannot give high dose insulin by IV straight. You need to give slow continuous insulin in managing patient with DKA atau HHS lah. So if you give insulin, once you give insulin, all this glucose will be absorbed into the intracellular. So what left in the blood is water kan? Water, because water will not be shift intracellularly by insulin, just the glucose. So you've got this dilutional effect. So dilutional, because what left is actually water and sodium. So you've got dilutional effect. Because when you talk about hyponatremia, okay, it can be hypervolemic hyponatremia, or it can be euvolemic hyponatremia, or hypervolemic hyponatremia, hypovolemic hyponatremia. Kan, faham tak? For example, if you drink a lot of water kan, this is what we call this patient with pseudo hyponatremia kan. If you drink a lot of water, plain water, you get dilution effect, you can fit. Okay, you can fit because what important, because sodium is intravascular solute. So what happen is the concentration of sodium. So if you drink a lot of water, plain water, you get hyponatremia, so you fit. So same goes with ni lah, with patient with DKA ataupun patient with a lot of sugar in the body. Because once the sugar shifted or metabolized, then you only get water in the vessel. Okay, faham kan? Okay, any other questions? That's why managing HHS, managing DKA, you have to monitor things that very important to monitor is hyponatremia, and also hypokalemia, and also the sugar itself. Okay. Because hypoosmolar and also reduction in osmolality, reduction in sodium, this can lead to cerebral edema. Okay, these are the complication in managing DKA, HHS is cerebral edema. Okay kan? Okay, any other questions? Okay, I want to give you guys tips. Okay, in order to be an outstanding doctors kan, the most important is you have to understand your physiology. Okay, if you understand your physiology, you can be a very good doctor. You can understand everything about the pathology, you can understand the pharmacology just by understanding the physiology, and you will become someone, outstanding lah. Because a lot of housemen, a lot of doctors, even MOs, they don't understand the physiology. Okay, so if you don't understand physiology, then you won't be able to manage patient accordingly, because you may not be able to learn everything kan. Contoh you tengah on call, okay, you on call medical, then suddenly you on call ONG lah, for example, you on call ONG, then suddenly patient in the antenatal ward fitted, okay, it may not without eclampsia lah, dia tak ada hypertension, dia bukan eclampsia, and then suddenly dia fitted. Okay, if you don't understand your physiology, then how are you going to manage? For example, maybe they fitted because of metabolic causes, fitted because of electrolyte problem. But if you don't understand your physiology, you won't be able to understand why. You won't be able to understand why patient fitted, and you won't be able to manage. A lot of patients, contoh doctors in orthopedic kan, orthopedic patient, orthopedic, contoh datang dengan BKA, datang for BKA kan, BKA for diabetic foot ke, for example, and then you did BKA, and then in the ward got complication, medical complication. If you understand physiology, you will be able to manage this patient. At least you get some idea lah how to manage. So that's why you need to know your physiology very well. Okay kan? Okay, so next presentation. After the second, kita kena rest for at least 10 minutes lah. Okay, so next.
Can you see my slide?
Okay, good.
So my name is Hazirah and I will be presenting about the child with joint pain. Okay, first when we talk about joint pain, the word that will come across our mind would be arthralgia and arthritis. So first, we need to know what is the difference between arthralgia and arthritis. Okay, first and foremost, arthralgia is a symptom. Meanwhile, arthritis is a diagnosis. So arthralgia is defined as pain or aching in joints. Meanwhile, arthritis, it requires the physical signs of the joint inflammation or the physical sign. For example, pain, stiffness, swelling, warmth, or erythema. And also it can be evidenced by röntgenographic signs, or meaning that the pain radiograph of the joint. For example, in case of osteoarthritis, in which you can find evidence of arthritis in the plain radiograph. For example, the reduced joint space, osteophytes, and so on. Okay. And then we go to the differential diagnosis of the joint pain. Okay, the differential diagnosis of joint pain is broad, ranging from benign to serious conditions. So we can conclude the categories of the possible diseases that can come with joint pain via the pneumonic arthritis, ARTHRITIS. So first, A, which is the avascular necrosis and epiphyseal disorder. So the examples are leg calf pertussis disease. Okay, leg calf pertussis disease is idiopathic avascular necrosis of the proximal femoral epiphysis, and also slip capital femoral epiphysis, in which in slip capital femoral epiphysis there is displacement of the capital femoral epiphysis from the femoral neck, usually at the epiphyseal plate. And then the second one, which is reactive and post-infectious arthritis. Okay, reactive arthritis is a broad term. It is broadly defined as an arthritis that develops soon after or during the an infection elsewhere in the body, and we cannot find the microorganisms in the joint. So it is infection in elsewhere in the body, but it is presented as joint pain. So for example, in the case of acute rheumatic fever, which usually occurs post streptococcal pharyngeal infection, then after 2 weeks, usually there will be joint pain. So acute rheumatic fever, example of reactive arthritis. And then trauma. Trauma could be accidental and non-accidental, so it's very important to rule out non-accidental injury in case of joint pain. can be presented with fracture or hemarthrosis, which is bleeding into the joint. And then in case of hematologic, such as leukemia and bleeding diastasis, in bleeding diastasis, for example, hemophilia, the patient can be presented with hemarthrosis, in which they'll be bleeding into the joint. And then in case of rickets, so this is under metabolic and endocrine disorders, can also be presented with joint pain. For infections, the common examples is septic arthritis or osteomyelitis. So for septic arthritis in children, to know the probability of the septic arthritis, you can use the Koch's criteria, in which there are 4 criteria. The first one, fever more than 38.5 degrees Celsius, WBC, white blood cell count more than 12, and then the ESR more than 40, and inability to bear weight. So for septic arthritis, the probability to get septic arthritis is 1 out of 4, it would be 3%. And then if 2 out of 4, it would be 40%, 3 out of 4, 93.1, and 4 out of 4, 99.6% to get septic arthritis. Okay, and then for tumor, the examples are musculoskeletal neoplasia, for example, osteosarcoma or osteoblastoma, lymphoma, and also neuroblastoma can also be presented with joint pain. And in idiopathic pain syndrome, the examples would be complex regional pain syndrome, CRPS type 1. Okay, CRPS is actually an amplified musculoskeletal pain syndrome in which the child will be presented with extreme pain, which is disproportionate to the history and also physical finding. And also there will be autonomic dysfunction, such as the child will have decreased temperature, cyanosis, edema, or increased sweating. And usually that will be presented with joint pain type 1, which is there is no evidence of nerve lesion, no definable nerve lesion. Compared to type 2, there will be definable nerve lesion. And also fibromyalgia, in which there will be generalized body pain. And then for systemic rheumatologic diseases. Okay, the most common chronic rheumatologic disease in children is juvenile idiopathic arthritis, which is JIA, also known as JIA. Okay, JIA, the criteria to diagnose JIA. First, the child must be less than 16 years old. Then second, the fever must be 2 weeks or more. And then the joint pain must be 6 weeks or more. And then it must have 1 out of the 4 criteria, in which the first one is the evanescent salmon colored rash. And then the second one, generalized lymph node enlargement. The third one, hepatomegaly or splenomegaly. And the fourth one, which is serositis. Okay, that is the criteria to diagnose JIA. And then systemic lupus erythematosus. There's also the new criteria, which is the EULA criteria for diagnosis of systemic lupus erythematosus. And then Kawasaki disease. Okay, that is for differential diagnosis. Okay, in order to approach a child with joint pain, it is also the same as other presentation. So you need to approach the child first by taking a thorough history, and then do physical examination, and then do some investigation, and let's manage the patient. So the first one for history. Okay, usually the child will be presented with the chief complaint of pain, swelling, or stiffness over the joint. So when the child is presented with this chief complaint, so what we want to ask. So we need to further characterize this chief complaint. Okay, we should ask about how severe is the pain, swelling, or stiffness. Okay, I will explain about this in details in the next slide. So first about the severity, and then ask about the location. It's about how many joints, whether it's monoarticular or polyarticular, and then the duration and the onset, and the progression, how quickly did the pain, swelling, or stiffness appear, and also the precipitating and also relieving factors. Okay, first, for severity, Okay, the pain is described as severe enough to cause the child to refuse to bear it. Okay, it's a red flag for serious illness. So what are the serious illness that can be presented with this red flag? For example, bacterial infection of the joint or bone, which is in the case of septic arthritis and osteomyelitis, and also in case of malignancy, for example, leukemia and osteosarcoma. And then sometimes the child cannot articulate that they are having joint pain, right? So we can ask the parents when the child, for example, has pain in the lower extremities, the child will refuse to walk, or sometimes this child is able to walk but with a limp. And then for upper extremities, the child will limit the movement and use the involved arm. So it is severe enough when it disturbs the daily activities of the child. For example, for lower limb, the child cannot walk or limping, and then cannot play. And then for upper extremities, the child cannot write, cannot button their shirt. So it indicates the severity of the joint pain. And then for the location and number of involved joints, okay, we need to ask the exact location of the joints, whether it involves the large joint or small joints, and then whether it involves a single joint or multiple joint. And for example, in the case of acute rheumatic fever, there will be migratory polyarthritis, right? Okay. And then for single joint, the example of the disease, septic arthritis or osteomyelitis, for example. So usually in the case of single joint, we have to suspect for infection, such as septic arthritis or osteomyelitis. And for GIA, it can be monoarticular or polyarticular, can be single or multiple. Lyme disease also can be single or multiple. Reactive arthritis can be single multiple. And trauma usually single joint. And malignancy could be single and multiple also. And for the condition that is systemic rheumatic condition, usually it will be multiple, such as SLE, juvenile dermatomyositis, HSP, JIA can be both. Okay. Next, for the frequency, duration, and also pattern. Okay, the pain can be persistent, intermittent, or migratory. So for persistent pain, usually it occurs in infection or rheumatologic disorder, the systemic rheumatologic disorder, and can cause also by neoplasm. Okay, for intermittent pain, particularly associated with activity, usually it occurs in mechanical problems, such as in mechanical problem could be in patellofemoral pain, meniscal or ligamentous injuries of the knee, rotator cuff impingement of the shoulder, and can also in hypermobility syndrome, such as in case of Ehlers-Danlos syndrome, and also Marfan syndrome. Okay. And then for migratory joint pain, the famous one would be caused by the acute rheumatic fever, and then HSP and also leukemia or lymphoma can also migratory. Okay, for the time of the day, usually joint pain due to arthritis, such as in case of GIA, usually worse at the beginning of the day and improve throughout the day with movement and activity. And meanwhile, pain due to trauma or mechanical cause, as I mentioned the example just now for mechanical causes, is usually mild, and usually while upon wake up, the patient does not experience any pain, but it becomes worsened with activity and will increase throughout the day. Okay, for acuity of onset, rapid onset of finding within 1 or 2 days is usually caused by infections such as septic arthritis or OM, and also could be caused by HSP. Okay, meanwhile, the other causes usually is not that acute compared to these three causes. Okay, for the onset, I put this in a table. For acute, subacute, and chronic. For acute, usually is defined as less than 2 weeks. Usually occurs in acute rheumatic fever, HSP, trauma, or also infection. Subacute usually caused by reactive arthritis, SLE, dermatomyositis, and leukemia, and chronic, more than 6 weeks, psoriatic arthritis, and also JIA. As mentioned before, JIA is the most common of chronic rheumatological disorder in children. Okay. For other joint symptoms, you need to ask the parents if there any presence of warmth or redness over the joint can indicate arthritis. Okay, and locking or giving way suggests mechanical joint disorder. Okay, for the precipitating factors, antecedent trauma, as I mentioned before, trauma could be accidental or non-accidental. So we need to be careful about non-accidental injury. If, for example, the history is not correspond with the finding that we find in the children. And for the non-accidental injury, usually there will be pathognomonic features such as there are bruises in the shape of the fingers, bruises in the shape of object that can be used to abuse the child. And then for antecedent infection, you can ask about recent infection. You have to ask about previous history of infection, RTI, UTI, and so on. Because it may indicate reactive arthritis, as I mentioned just now, right? Okay, for inactivity, in some diagnoses, it may be exacerbated by inactivity, and in some diagnoses, it may be exacerbated by physical activity. For example, in the case of JIA or SLE, which is a chronic inflammatory arthritis, usually the pain is exacerbated by inactivity. For example, usually the parents will describe the child upon waking up from sleep as look like an old man, because it is usually the child will be usually irritable and having joint pain early in the morning after waking up, because after prolonged inactivity right during sleep. And then there will be also complaint of joint pain during after a nap or after prolonged inactivity, for example, and after long ride in the car, and also after sitting still in the class, on the chair in the class. So they'll be experience more, it'll be more painful. So that is in the case of JIA or SLE. Meanwhile, in the case of mechanical disorder, such as hypermobility syndrome, osteochondrosis, or patellofemoral pain syndrome, the child usually will be more painful when there is physical activity, and it will improve when the child rests. So, and for the review of the symptoms, for the clinical features, we need to ask about rash or other abnormalities in the skin. Okay, because some systemic disease can be presented with rash and weight loss in the systemic disease, and also malignancy. Abdominal pain can be in HSP or in IBD. Okay, so diarrhea and neurologic symptoms. In SLE, which can be presented with neurologic symptoms and eye abnormalities. For example, in case of Kawasaki, in which there will be conjunctivitis. So we need to ask about the systemic symptoms also. Okay, this is the serious diagnosis and associated findings in children with joint pain or swelling. So the first one, which is septic arthritis or osteomyelitis. Okay, the child will be hectic, spiking fever. There will be high temperature, ill appearance. Can also present it with some rash, and usually for septic arthritis, it will be monoarthritis, single joint, and rapid onset. And the patient can be also presented with pseudoparalysis because the child doesn't want to move because of the pain. And then can have pinpoint bony tenderness in osteomyelitis. For Kawasaki disease, patient can be presented with hectic fever, usually prolonged fever, more than 6 weeks. More than 5 days. Prolonged fever more than 5 days. And then the child will be irritable and sentinels, vitamins, enlargement, conjunctivitis, oromucositis, peripheral arthralgia, edema, rash, carditis, and feeling fingertips. For neoplasia, usually the child will be irritable, pallor, and explain bruising, and also bone pain. And for neoplasia, it is described as the joint pain usually occurs at night, nocturnal, but it can also persist on the day. For non-accidental injury, so we need to be careful if there is disparities, differences between history given and also features on examination. And the child is irritable, fat, pale, and explain bruising and other injuries such as bone pain. Okay, we need also to ask about fever. Okay, high fever, more than 38 degrees Celsius, in a patient come with sudden single joint pain is a typical of bacterial infection of the joint or bone. So fever also can be presented during antecedent illness, such as reactive arthritis, as I mentioned before, right? So the patient can have previous infection before developing reactive arthritis. We could ask about the history of fever before. And then fever is also associated with non-infectious diseases in the systemic rheumatologic disease such as JIA, Kawasaki, vasculitis, such as in case of HSP and also SLE. So for JIA, it is described that the fever is quotidian in nature. Quotidian is also described malaria, right? So quotidian fever is the patient having daily spike, meaning that every day there will be daily spike of fever, usually in the afternoon or evening, and then the fever will resolve in the morning. Usually there will be daily spike of the fever and resolve every day. Then for SLE, it is described that the fever is usually gradual in onset, low grade, and also intermittent in nature. Okay, next we move to physical examination. Okay, first we need to look at the general appearance of the child, whether the child is ill or well appearing, because usually the child is ill looking, so it might suggest infections such as septic arthritis or osteomyelitis, and it also can be in malignancy. Okay, and then we look at the change in the patient's growth curve. We need to plot the growth chart, and also recent weight loss can indicate serious or chronic disorder such as GIA, SLE, inflammatory bowel disease, or malignancy. Okay. And then vital signs such as blood pressure, we need also to check because it can be elevated in SLE and also primary vasculitis, and the temperature to look for the fever. Okay, and then after general appearance, we need to check for the systemic, check for the cardiovascular, check for the eye, because for the systemic illness, there will be also systemic manifestation. And then we need to look at the skin also. For the skin manifestation in SLE, there will be photosensitive malar rash and also nasolabial spare. I will show you the photos later. And then for JIA, in which there will be faint evanescent rash, salmon color. Salmon is like pink color, so evanescent is pudar. So acute rheumatic fever, there will be erythema marginatum, juvenile dermatomyositis, helicotron diffuse or heliotrope rash. HSP, there will be palpable purpuric rash, usually on the extensor of the lower limb. And Lyme disease, there will be erythema migrans. So this one is the malar rash in SLE. You can see the malar rash, and there is nasolabial full spare. Okay, then salmon colored rash. I think it's because it's pink color, same as salmon, so it's called salmon colored rash or evanescent rash. Okay, in JIA, and then purpuric rash in HSP. It is palpable and non-blanching. Okay, for Gotron papules, there will be erythematous, and also usually at the bony prominence for Gotron papules. And for heliotrope rash, usually there will be purplish or bluish reddish in color for heliotrope rash in case of dermatomyositis. And this is to differentiate between erythema migrans and erythema marginatum. Okay, erythema marginatum is in rheumatic fever, in which you can see in erythema marginatum there is center clearing. So at the center part it is clear, compared to erythema migrans in Lyme disease, in which the bull's eye rash will be redness at the center compared to here, which is center clearing. Okay. And then we go to the focus joint examination. For focus joint examination, we must do it at the end because it can be extremely painful, and if we do it at first, then the child will be irritable. So we want the child to be cooperative, we do it at last for focus joint examination. First, for inspection, we have to compare both extremities, looking for differences in size or shape, looking at if there is any swelling, and also change in shape. And then you look at the skin overlying the joint. Look at for the evidence of scar, for trauma, bruises, discoloration, which is also can be caused by rash or inflammation. And then for palpation, first we need to check for temperature. It will be increased in the increased temperature in the affected joint in case of inflammation such as infection or rheumatologic disorder. And then palpate for tenderness. Okay, locate the tenderness. If swelling is present, palpation may help to determine the nature of the enlargement. Meaning that we look at the swelling whether it is cystic, trophy, or hard in nature. For cystic, could indicate fluid collection that may be indicative of joint effusion, ganglion, meniscal cyst, bursa swelling, or abscess. If drophy or rubbery consistency can be synovial thickening, and hard or bony feel may indicate osseous overgrowth, such as in case of bone tumor or exostosis. Okay, and then lastly, for the physical examination, we check for the range of motion. Okay, if the ROM is limited, so we need to check to what degree the range of motion is limited. If there is any pain with motion, and if the muscle strength is normal. Okay, next we move on to the diagnostic studies. Okay, first one is joint aspiration. Okay, joint aspiration is said that it is not necessary for most children with joint swelling and pain. If the child is lack of features of sepsis, such as the child is not febrile, does not ill looking, and can bear weight, and can still use extremity, so we don't need to do joint aspiration because there is no evidence of sepsis. Okay, for if we do joint aspiration, can send it for cell count in differential. There will be high white cell count in inflammatory process such as KIA or septic arthritis, Grimston, glucose, protein, and microbe. Send for cultures. And then for imaging, for the most commonly done imaging is plain radiograph, in which in plain radiograph we can find fractures, periostitis, avascular necrosis, hematologic malignancies, and then bone tumors and also bone dysplasias. For MRI, it is done usually in case we suspect any bone infection, traumatic joint injury, or tumor. For CT scan, we usually do it when the fractures that we cannot find in plain radiograph, so we'll do CT scan. Okay, next for laboratory testing. First, we do the complete blood count and differential. In case of SLE and JIA, there will be sometimes there will be leukopenia and also thrombocytopenia. And in bacterial and viral infection, there will be leukocytosis. In leukemia, there will be lymphocytosis. And then in acute phase reactant, can do ESR or CRP. It is non-specific markers of inflammation. So in case of inflammatory joint pain, can be raised, and can do liver and kidney function tests. Can be abnormal in systemic disorders such as SLE or HSP. And if there is myositis, CK can be also elevated. In the case of malignant mutism, can also have elevated LDH. For urinalysis, abnormalities may be seen in some rheumatologic disorders such as SLE, vasculitis, IgA vasculitis, and HSP. Okay, this is laboratory testing for acute joint pain and also chronic joint pain. So for the first one, which is acute joint pain, we can do cultures of the throat, blood, stool, and urine, because as I said before, there might be reactive arthritis, right? So we may find evidence of infection through cultures. And then serologic testing. For Lyme disease. Serologic testing for Lyme disease. For children who live in or have visited endemic area. So Lyme disease is common in America. Lyme disease is caused by Borrelia burgdorferi. It is a vector-borne disease. So for SLE, we can do ANA or anti-dsDNA. Okay, if we suspect the child has SLE. And for TB arthritis, we can do MAN2 tests. Okay, let's move on to the management. Okay, management is based on etiology. If the patient has infection, we treat the infection. If the patient has systemic illness, we have to treat the systemic illness according to the diagnosis. And then it must involve multidisciplinary team. So it must involve pediatrician. If necessary, it must involve the orthopedic surgeon or the rheumatologist and so on. And we can do also physiotherapy. We have to do exercise program for the child to strengthen the muscles and also keep the joints flexible and encourage the normal limb development. So usually management is aimed to maintain function and also prevent deformities. And for example, if the child is having pain, so we can give analgesics or anti-inflammatory drugs such as NSAID to reduce the joint pain. In case of infection, we can give antibiotics. And in hematemesis, can do joint aspiration to get rid of the blood from the joint. Okay, these are my references, and I think that's all. Thank you. Okay. Any question?
Okay, good. Any questions? So any questions to Hazirah? Okay. Okay, so basically this is a very important topic. Again, this is not that common, but it's important. Okay. I can share you some. I got two cases of patient. I mean that reflects a very important. Very important pathology that you have to consider in your daily practice. Okay. One patient. I've got one patient. This is a child. I think now 13-year-old. Referred to us when I was in endocrine back in USM. Referred to us by adult endocrinologist from HPZ. So actually referred to us for short stature and also Cushingoid lah. Basically Cushingoid, short stature. So basically after we we do like a lot of endocrinology testing, endocrine testing on this patient. And then after we took a detailed history, it turned out that this child actually in the initial presentation is actually joint pain. Okay, it's a polyarthritis, symmetrical polyarthritis of more than 6 months. We think the initial presentation is GIA lah, and associated with prolonged fever. And then went to GP. Both parents are teachers, so went to GP. And then GP start steroids. Remember, GP, if you come GP, never start long-term steroids to your patient without a proper follow-up. So this child was started on steroid, high-dose steroid, with apparently, because this is a growing child, all this happened since I think about 7 or 8 year old lah, since he was 7 or 8. So because of high-dose steroid, it affected. So patient developed Cushing, and then the steroid actually destroyed the growth plate. So patients subsequently, when referred to us, already short stature, severely Cushingoid, and because of the steroid, it's actually its effect. Patient got osteoporosis, and also patient got the pituitary axis growth. The pituitary hypothalamus axis was disrupted because of the chronic steroid. So subsequently, it's very difficult to manage this child. Now patient required like prolonged steroids. On top of that, hormone therapy replacement, growth hormone replacement, and so on lah. But because actually because the GP missed the initial diagnosis of GIA. So it wasn't treated carefully lah, and patient got complication. And the other case we've got, when I was in HRPZ, I'm doing ID, infectious disease. We got a child referred from Polakrai, admitted for few months, for actually 1 month for about 2 weeks in Kuala Krai, and then transferred to HRPZ, admitted for another month for prolonged fever. All investigation done because it was referred to infectious disease. So we investigate along the line of infectious diseases. So we send all serology, and turned out to be myelinosis was positive. My serology myelinosis was mildly positive, so treated with prolonged antibiotic. But subsequently, when she attended the first TC after discharge, she came with swelling of wrist swelling. So I happened to see that child, and then after further questioning, after 2 months of in and out of hospital, the father said they just remember that patient actually got the first, because patient actually is not a prolonged fever, it's an intermittent fever, like 1 week fever, and then it's resolved, and then came back with another fever, episodes of fever associated with actually joint. Each time patient develop fever, she will actually present it with joint swelling. So we did all the rheumatology screening, and then we send the patient over to rheumatology now. Actually, rheumatology is a good prospect. If you like rheumatology, especially pediatric rheumatology, that's a good prospect, because in Malaysia there's only three pediatric rheumatologists, and the only center in Malaysia is in Selayang. There are pediatric rheumatologists in Penang and in Johor, but the only training center is Selayang lah. Even HKL pun tak ada rheumatologist. And this is very, very, very difficult. Not very difficult. I mean, very, we call it ignored area of pediatric medicine now. And then it's not that uncommon. It is quite not really a rare disease. You will come across some, especially SLE lah. SLE is very common. We know this SLE is a disease of equator, kan? You've mentioned just now Lyme disease common in America, but apparently we've diagnosed one Lyme disease in Kemaman when I was MO in Kemaman. Lyme disease, usually the history is they've got history of tick bite. What good is tick is very common in Malaysia, kan? Apa nama? Pirah kan, pirah. You call it pirah kan kat Malaysia ni. Pirah is a vector for Borrelia tau, for Borrelia Rudolferi. So we've diagnosed one murdosis in Kemaman. But apparently not Rickettsial disease, like ticks, like Lyme disease, all these yellow fever, Q fever, semua benda ni is quite rare lah in Malaysia. This is a group of disease we call it Rickettsial disease. Okay, it's part of it's actually not autoimmune, but it's zoonotic lah. It's usually from animal vector. These are actually some of the differences that you have to bear in your mind lah. And then what else? Joint pain. And we are seeing more petis lah. Petis is more common. Now we are seeing more and more petis. Okay, you've mentioned petis is a mechanical problem kan? It's a avascular necrosis of the neck. So in adult, in old people, you've got avascular necrosis kan, of the neck of femur. So in pediatric, you also got avascular necrosis of neck of femur. This is what we call petis disease. It's the same pathology, but the causes is slightly different. Usually they are fat, obese, because we are seeing more obese children nowadays. So we're seeing more petis. Okay, you definitely will see one petis at least in your life, if you diagnose correctly. Okay, and then it's right. I said SUFE. Sorry, not petis. SUFE. You'll diagnose SUFE. This SCFE. We call it, sometimes we call it SUFE, sometimes we call it SCFE. What's up again? Hematrosis, you'll see especially in hemophilia. Okay, hemophilia. I think UIA we've got one. I think one hemophilia boy. Hemophilia is quite rare at the moment. It's become rarer because now, I mean, women get the choice of termination of pregnancy now for hemophilia. So if you diagnose early and antenatally, if diagnosed hemophilia, you can actually terminate the pregnancy. It's very expensive disease to treat. Government are reluctant to treat now. And then what else? Okay, leukemia, hematological malignancy. Usually they don't present with joint pain. They presented with bone pain. Okay, it makes sound. So that's why when patient came with joint pain, you have to clarify: is it joint pain, is it arthralgia, or is it arthritis, or is it actually bone pain? Okay, because in leukemia and bleeding and hematological malignancy, the cause of pain is actually the marrow hyperactivity lah of the marrow causing the pain. Okay, because you have to remember your periosteum, you've got pain receptor on your periosteum. Okay, so when it is what you call it, stretch, then you can get pain. Okay, what else? Tu je kot. Rickets. Actually, rickets they don't come with pain. Rarely rickets come with pain. They come with bone deformity. Okay, slaying of the wrist joint, bowing, benda macam tu lah. And then infection, okay, septic arthritis, osteomyelitis, okay, correct. Okay, rheumatic fever, okay lah. The rest is okay lah. Tumor, again, osteosarcoma, Ewing sarcoma, okay, these are the two common pediatric bone tumor. Especially osteosarcoma lah, usually they presented at the joint area kan. And you need to know lah how to differentiate osteosarcoma and Ewing sarcoma, because this is the two most common pediatric bone tumor kan. You know, the exterior appearance, the sunburst, and also the onion peeling kan. Okay, and then idiopathic pain syndrome. This is not that common in pediatric. It's very rare in pediatric. It's all patient. Arthritis macam giant cell arthritis, is very rare in pediatric. And then rheumatological disease, JIA is common. The other name is still disease. I think actually among all the systematic disease, the most common is SLE, and second is JIA. Kawasaki is systemic disease, but they actually rarely presented with joint pain. Actually, my daughter got Kawasaki, and I've seen a lot of Kawasaki lah, because I'm fortunate to be trained in USM lah, because we've got cardiologists, we've got genetic metabolic specialists, we've got neurologists who actually manage all this connective tissue. And then in Kelantan, we've got visiting Dr. Tang, which is the only rheumatologist in Malaysia who actually visit us. So I've seen a lot. I've seen a few rheumatology condition. So any other questions?
Assalamualaikum, Doctor. I have a question.
Mhm.
First and foremost, this question with regards to the juvenile dermatomyositis. As part of the criteria, mentioned that EMG and also muscle biopsy is one of the criteria, but do we do it regularly, and when do we do it? First, second question would be that in systemic onset of JIA, we need to start with the high dose systemic steroid first, and then we can consider to start methotrexate if there is a highly active disease. May I ask, like how long do we set the time before we want to start the methotrexate in systemic onset JIA?
That's a very difficult question. See, the first one, dermatomyositis kan. Want to do EMG. Actually, because you need to, if you want to do EMG, you need expertise. Okay? Not all neurologists can do EMG lah. Biasanya actually, if you go to UK ke macam tu kan, most countries, developed countries, EMG, EEG, EMG, nerve conduction semua ni is done by neurophysiologists, bukan neurologists. Okay, these are all neurophysiologists. They are not doctors. So a lot of neurologists cannot actually do ni. Cannot actually do EMG semua lah, unless few center. Tapi macam USM kita orang buat EMG. I mean my specialist Prof Salmi, she do EMG lah. So in dermatomyositis, usually EMG is not a must lah. It's not a must. If you got a straightforward, because a lot of this rheumatology disease kan, you diagnose by history. First is by history, supported with your serology punya marker lah, you punya immunoglobulin, you punya autoimmune screening. Tapi sebab because this is rare, I pernah jumpa sekali je dermatomyositis. Itu pun it's not dermatomyositis, it's myositis. Because it presented with, if you take history carefully, you can actually pinpoint it's not actually joint pain, it's actually muscle pain. They've got muscle pain lah. It looks like bone pain, but it's actually muscle pain. And most of the time it's actually it's distal muscle rather than proximal muscle. And proximal, I can't remember. Got one. And then the CK usually is high. You've got this idea, because if joint pain, dia tak ada CK, high CK tau. Muscle pain got high CK. And then because and then usually kita hari tu kita tak buat pun EMG. We just diagnose via serology dengan history je. By clinical examination. Lepas tu, yang tu kot. I don't think EMG is the gold standard. I'm not sure, because to be honest, rheumatology ni memang susah, and I pun tak pandai sangat rheumatology. And then the other one, pasal, apa yang tanya tu ni? Lupa lah. The second question. Oh, pasal ni, steroid kan?
Steroid, okay.
Okay, actually JIA, usually, it depends lah. Some JIA, you just induce them with steroid, and then they will attain remission. Okay, bear in mind, a lot of rheumatology condition kan, all this rheumatology problem is these are chronic disease, and the cause, there's a various causes lah. Sama macam SLE, dia ada sama macam MS, SLE, so they've got relapse limiting causes. Ada yang just relapse once and then remit, once relapse and then remitted. Ada yang tak remit, just partial remission, just achieve partial remission. Same goes with JIA. JIA, some patient, they once you induce and then they remit forever. So they don't need any maintenance. But most of them need maintenance. I'm not sure how they do it, how the rheumatologists manage it. But in USM, biasa we just induce them with steroid or metylpred lah. Biasa induce with metylpred. And then kita maintain with prednisolone. And a lot of them works lah. A lot of them actually works. And then occasionally methotrexate rasa tak nak guna pula. Because I think a lot of people, I think there's a lot of choice kan ni. DMARDs kan, kita ada banyak choice of DMARDs kan. Kalau pediatric, kalau rheumatology, usually they use azathioprine, sulfasalazine. Biasanya azathioprine lah, azathioprine. Kalau macam USM, kita orang biasa guna CSA, cyclosporine dengan CPM. Because methotrexate ni problem dia tu lah fertility and also growth lah. Dia problem dengan growth dan fertility, which is in pediatric tuan tak suka sangat. Okay, rasa jarang kena methotrexate. Tapi I'm not sure. Kena tanya rheumatologist. Tapi kalau kat USM tuan jarang kena methotrexate. Okay, any other questions?
Thank you, Doctor.
Doctor.
No.
Hello. I have a question regarding the history. Sometimes pediatric patients have difficulty to pinpoint the pain. So, is there any tips that can help us to differentiate? Is it a joint, bone, or the muscle pains?
It's very difficult, especially young lah, especially macam JIA kan, they present very early, they are very young lah, JIA ni. Kalau SLE usually slightly older. That's the difficult part lah, especially in examination kan. When you examine pediatric patient, you have to be opportunistic, okay. For example kan, rather than you assess, because it's very difficult, they don't obey command kan, especially if you want to assess power of the lower limb dengan upper limb kan. So instead you kena buat make it a play lah. Contoh macam you nak assess muscle kan. So you suruh dia orang baring and then you look for Gower sign for example. So you know that is proximal muscle problem. Atau you suruh dia orang tiptoe. Macam you bagi gula-gula, macam you letak gula-gula atas kepala kan. So suruh dia orang tiptoe to get the sugar, the sweet kan. So by tiptoeing then you tahu, okay, patient tak tiptoe, then most likely is distal muscle problem. Kalau joint is more difficult because if you got joint pediatrics, sometimes they complain joint pain kat knee, but it's actually referred pain from the hip. So this is the role of imaging lah. The role of imaging. Biasanya imaging will help. Tapi against arthritis, imaging is difficult. Okay, imaging is difficult. Unless kau memang ada swelling, gross swelling, then you boleh buat ultrasound. Tapi by X-ray is very difficult lah. You need to have skill. Susah lah, memang susah lah kalau untuk ni. Especially arthritis. Kalau bone pain tu is okay lagi. Tapi kalau joint pain tu memang susah. You need to be opportunistic. And then you need to correlate dengan other things lah. Itu juga yang rasa boleh jawab.
For example, doctor, like the patient might refuse to put weight on the affected side. Is it there is a pointing towards the pain, or is it is just regarding the severity of all the possible causes?
Itulah, kalau patient refuse to weight bear, then you have to think whether this is can be fracture ke, it can be joint problem, it can be bone problem, it can be muscle problem. Yang susah tu, so you kena correlate. Okay, because usually if it is muscle pain, it will associated with weakness. Okay, so kalau you tengok patient refuse to weight bear, and then you assess neurological, you assess power memang reduce. Then mostly this is muscle problem lah, because it's about muscle lah kan. And then you can boleh check CK level. Kalau muscle usually CK dia akan high. And then kalau dia joint, biasa arthritis will present with swelling. Okay, arthritis because it's inflammation, so dia akan ada swelling. Arthralgia may not present with swelling. Okay. So it helps. Contoh kalau arthralgia usually fracture lah, biasa fracture. ataupun mechanical. Tapi arthritis is inflammation. So biasa contoh patient dengan arthritis dia akan datang dengan warmness around the joint, systemic symptoms like fever. So you have to be, you have to correlate everything. It's memang difficult. Okay, kalau memang bone joint problem, memang kalau dia tak wet bear, you susah nak just simply not wet bearing, you susah lah nak differentiate. Okay. So kita ada sometimes we got admission, referred from orthopedic with initial diagnosis of septic arthritis. So admitted to orthopedics, but actually it's not septic arthritis, it's actually myalgia. Sometimes patient datang dengan reactive arthritis ataupun usually reactive arthritis, myalgia lah, proximal myalgia ke distal myalgia. Even sometimes kita ada patient yang datang transverse myelitis tapi was wrongly diagnosed at ED level, admitted to ortho because of kata septic arthritis atau reactive arthritis, but it's actually it's a transverse myelitis, it's a neuro problem. I've got one, it's a spine problem. Because sudden acute paralysis lah, tapi admitted to ortho ward. So macam tu lah. It's difficult.
Thank you, Doktor.
Okay, ada soalan lagi?
Doktor, for joint pain, kalau reactive arthritis ni, we put it on top of the list ke? It is a diagnosis of exclusion.
Okay, reactive arthritis is usually diagnosed with exclusion, but you can have clue lah. For example, memang dia ada history of in the past 1 to 2 weeks memang ada history of infection, especially URTI. Then otherwise patient is well, there's no sign of chronicity, because remember this autoimmune disease kan, vasculitis semua ni, usually it's a chronic disease, and most of them has relapse remitting punya pattern. So they have relapse and then remits. Usually they do have, if you ask proper history, they do have similar presentation in the past. Dulu memang ada lah dia sakit kaki and then ada demam for 1-2 weeks, tapi hilang je lepas tu. So saya tak buat jumpa doktor. Usually that kind of stories lah you heard from the parents. Tapi kalau reactive arthritis is a one-off, very significant. Most of time parents can clearly say, minggu lepas ada runny nose, ada URTI, macam tu lah. Biasanya macam tu. You can exclude by history. Okay, memanglah kita ada diagnosis exclusion means kita kena rule out everything else. But a lot of time, even though it's diagnosis exclusion, there are few things that we just have to exclude major diagnosis without like second or third line investigation to actually conclude this is reactive arthritis. Principle is, when managing a chronic disease, as long as there's no alarming symptoms, kan? Contoh you buat X-ray tak ada joint disruption, then you may have sometimes untuk think and untuk observe. Atau contoh patient tak debilitating kan, contoh patient joint pain tapi mild pain, no problem with function kan, joint function still okay, development still, patient still growing, systemic symptoms so not that much, then you can actually observe and also take your time to think. Okay, it's not something like urgent. The only urgent is septic arthritis. Frankly speaking, the only urgent is septic arthritis. The rest is not that urgent. Even SLE is not that urgent unless kalau dia datang dengan lupus nephritis ataupun lupus cerebritis, then the rest is not that urgent. Okay, you can take your time. And if this is reactive arthritis, then after 1-2 weeks, patient akan resolve lah. They are usually very happy, except they don't want to wait there. They are usually very happy. Okay tak? Ada question kan? If not, we can rest for 11:20 lah, kita jumpa. Boleh tak? Last presentation kan? 3 je kan?
Boleh.
Okay. Okay, see you next in 15 minutes. Okay.
Thank you, Doktor.
Okay, so let's start. Prolonged fever.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So we present about the child with prolonged unexplained fever, or also known as fever of unknown origin. Okay. Okay. Throughout this presentation, I will touch about the definition of fever, mechanism of fever, definition of fever of unknown origin, and its classification, etiology, and approach to children with fever of unknown origin. So first we go to the definition of fever itself. So according to Nelson, fever is defined as a rectal temperature more than or equal to 38 degrees Celsius. And if the temperature is more than 40 degrees Celsius, it is called as hypopyrexia. And according to Sunflower textbook, fever in children is a temperature of 37.5 degrees Celsius. And the auxiliary temperature underestimate the body temperature by 0.5 degrees Celsius. So that is the definition of fever. Next, we go to the mechanism of fever itself, which is divided into three mechanisms according to Nelson, which is Pyrogens. The second one is heat production exceeding heat loss, and example of the heat production exceeding heat loss is salicylate poisoning. So in patients who have salicylate overdose, the salicylate can increase the metabolic rate and leading to the heat production and causing fever. And in malignant hyperthermia, it is a hypometabolic crisis which occur in malignant hyperthermia susceptible patient who is exposed to a volatile anesthetic such as halothane. So when this patient is exposed to this volatile anesthetic, it can cause calcium accumulation at the muscle and cause sustained muscle contraction, which generates more heat production in the body. And this heat is more than the body able to dissipate and causing fever. And the third mechanism of fever is defective heat loss, which occur in patients who have ectodermal dysplasia. So what is ectodermal dysplasia? It is a disorder in which two or more of the ectodermally derived structures, such as the skin or the sweat gland, that develop abnormally. So in this patient, when the sweat gland is developed abnormally, the patient can have less sweating or no sweating at all. And when there is no sweating, then it will be defective heat loss to the surrounding and lead to fever. And in patients with victims of severe heat exposure, our body actually can dissipate the heat in our body by the process of evaporation or conduction. So however, in patient who is exposed to a severe heat exposure, the body is unable to dissipate the heat efficiently. And for the pyrogens, I will further discuss in the next slide. So for the pyrogens, it is started with the presence of the exogenous pyrogens in our body, such as the microbes, microbial toxins, drought, or malignancy or inflammatory diseases. So these exogenous pyrogens will stimulate the release of endogenous pyrogens, such as cytokines interleukin 1 and interleukin 6, TNF alpha and interferon beta and delta, beta and gamma, leukocyte and other cells producing lipids. And these endogenous pyrogens will be excreted into the circulation and reach the anterior hypothalamus. So when it reaches the anterior hypothalamus, it will release the arachidonic acid in the anterior hypothalamus, which is then metabolized to prostaglandin E2. Okay. And then with the complex interaction between the complement and the prostaglandin E2, it will increase the thermostat set point in the anterior hypothalamus. So when there is increase in thermostat point at the anterior hypothalamus, the body will trigger the heat conservation and also increase heat production mechanism. In heat conservation, the body will activate the neurons in the vasomotor and causing vasoconstriction. So when there is vasoconstriction, there will be decreased heat loss from the skin and lead to the cold periphery in hands and feet. That's why during fever, we can feel the cold sensation in hands and feet. And the second mechanism is increase the heat production by the brown fat and also increase heat production in the periphery. shivering, and also increased metabolic activity. Besides that, the heat will also increase in our body when there is behavioral instinct, such as when we have fever, we tend to seek warm rooms and add extra clothing and reduce our activity. So this mechanism can increase the heat in our body and reach the set point of the thermostat. And the hypothalamus will maintain the new setting at febrile temperature just as in normothermic level. So this mechanism later will cause fever. So we go to the definition of fever of unknown origin. What is fever of unknown origin? It is defined as children with fever documented by healthcare provider and for which the cause could not be identified after 3 weeks evaluation as an outpatient or after 1 week evaluation as inpatient. So why healthcare it must be documented by the healthcare provider, because we want to avoid the infectious disorder, whether the patient or the caretaker of the patient make up the symptom of fever. So the fever of unknown origin must be documented by the healthcare provider. So for the classification of fever of unknown origin is classified into classic fever of unknown origin, healthcare associated fever of unknown origin, immune deficient fever of unknown origin, and the last one is HIV related fever of unknown origin. So the first one is the classic fever of unknown origin. It is affecting the previously healthy patient, and it is defined when the fever is more than or equal to 38 degrees Celsius and the fever lasted for more than 3 weeks, and the patient has go to the hospital more than 2 times, or has more than 1 week fever for inpatient. And the causes for the classic fever of unknown origin can be cancer, infection, or inflammatory disease. For the healthcare associated fever of unknown origin, it is a fever which is more than or equal to 38 degrees Celsius, which is lasted more than 1 week, and not presenting or incubating on admission. So the patient at first come for other reason, but however after staying in the hospital, the patient suddenly developed a fever which lasted for more than 1 week, and the cause can be hospital-acquired infection or post-operative complication. The third one is immune deficient fever of unknown origin. It is fever more than or equal to 38 degrees Celsius, which is lasted for more than 1 week, and negative culture after 48 hours. And the patient is known to be immunocompromised, whether the patient is on chemotherapy or on immunosuppressive drugs or have underlying immunosuppressive disorder. And majority the cause of the immune deficient fever of unknown origin is infection. Okay, and the last one is HIV related fever of unknown origin. It is fever more than or equal to 38 degrees Celsius, lasted for more than 3 weeks for outpatient or more than 1 week for inpatient, and the patient has HIV infection confirmed. So the causes for the HIV related fever of unknown origin can be HIV or opportunistic infection such as toxoplasmosis. Next, we go to the etiology of fever of unknown origin. The main etiology of fever of unknown origin is can be infection, inflammatory diseases, malignancy, and others. So the most common one is the infection. Majority of patients with fever of unknown origin is infection, followed by inflammatory disease, malignancy, and miscellaneous others. And actually, most fever of unknown origin result from a typical presentation of common diseases. So these are the long list of diseases that can cause fever of unknown origin. So for the infection, the most commonly implicated in children with fever of unknown origin is salmonella, tuberculosis, syphilis, Lyme disease, and also can be cat scratch disease. So it can be also other infection like Rickettsial diseases or chlamydia diseases. For the inflammatory diseases, the most common is SLE and also juvenile idiopathic arthritis. which both are the connective tissue diseases. And other than that, the common one could be Kawasaki disease and also inflammatory bowel disease. And fever, which lasts for more than 6 months, is actually uncommon, and it suggests granulomatous autoinflammatory or autoimmune disease. Okay. So, etiology. Next, we go to the approach to child with fever of unknown origin. What we want to evaluate in patient who come with fever of unknown origin. The first one, we have to identify or recognize the age of the patient, because according to Nelson, the patient who age more than 6 years old, it suggests that the patient can have respiratory or genitourinary tract infection, localized infection, juvenile idiopathic arthritis, or leukemia. In adolescent, the patient commonly have inflammatory bowel disease, autoimmune disease, lymphoma, or tuberculosis. So for the fever itself, we have to further ask about the fever, about the onset of fever, frequency of fever, duration of the fever, pattern of the fever, which I will further explain after this, and the response to treatment. Because in patients who have lack of response to anti-inflammatory or antipyretics, it may suggest the cause other than infection or rheumatologic disease. And if the patient have repetitive chills and temperature spikes, it suggests septicemia. And the fever need to be confirmed by someone other than caregiver, as I mentioned before this, because we want to rule out the infectious disorder. Okay. Then we go to the pattern of fever. The first pattern of fever that we describe is the continuous fever. It is the fever that never touches the baseline, which means that the fever never remit with little or no fluctuation. And the example of fever that have continuous fever is typhoid fever. But typhoid fever can also be staphylococcus fever, typhus fever, drought fever, malignant hyperthermia, or brucellosis. For the intermittent fever, it is defined as temperature falls to normal each day. And quotidian fever in malaria is also under intermittent fever, like Hazirah said before. The fever occur every day, but the temperature falls to normal in each day. So the other example of intermittent fever is Pyrogen infection, lymphoma, and TB, and also JIA. And then the remittent fever. Remittent fever means that there is daily fluctuation of the fever more than 2 degrees Celsius. But however, the temperature does not return to normal, and it is not characteristic of any particular disease. The fourth one is relapsing fever. Relapsing fever means that the temperature returns to normal for some day before the temperature rises again. And the example of relapsing fever are malaria and also lymphoma. So for malaria, the relapsing fever in malaria is station fever pattern of which caused by Plasmodium vivax or Plasmodium ovale, and the second one is quartan fever, which is caused by Plasmodium malaria. So for the patient fever pattern, there is 3-day pattern where the patient have fever at day 1 and no fever at day 2, and occur fever again in day 3, and it continue in the same pattern. For the quartan fever, the fever occur in 4 pattern way, which the fever occur at day 1, no fever at day 2 and day 3, and fever occur again at day 4, and continue in the same pattern after that. So for the lymphoma, pale abstinent fever is also one of the example of relapsing fever. It means that the fever lasts for 3 to 10 days, followed by a febrile period for 3 to 10 days, and the fever occur again for 3 to 10 days, and it continues. And it usually occur in Hodgkin lymphoma, and it specifically in Hodgkin lymphoma. And then for the staphylococcus fever, it is continuous in nature, where the temperature rises gradually to a high level, just like the step of the ladder, and it is specifically for the typhoid fever, like this graph. Okay, next, other than fever, what we would like to ask in the history of patient with fever of unknown origin is about the associated symptom. We have to ask if there is any other generalized symptom like malaise, lethargic, because in patient with infectious fever, usually the symptom is only fever. There is no other systemic symptom like malaise. And also we have to ask if there is any systemic symptoms such as malaise, headache, and myalgia. When the symptom persists, when the fever stops, it suggests systemic disease. You also need to ask if there is any weight loss which can suggest lymphoma or malignancy, rash which can suggest juvenile idiopathic arthritis, and we have to ask sweating, which may suggest hypothyroidism, and if there is no sweating during the episode of fever, usually it suggests infectious disorder. And we have to ask about the conjunctivitis, red eyes in layman term, because it suggests Kawasaki disease, leptospirosis, TB, or tularemia. Then we need to ask about the nasal discharge, because it suggests rhinosinusitis. And so ask if the patient have sore throat, which is recurrent. Because recurrent sore throat, it can suggest periodic fever with abscess, stomatitis, pharyngitis, adenitis syndrome, which is also known as PFAPA syndrome. It is a recurrent periodic fever syndrome that occur in the patient. It is recurrent. And then we have to ask about the GI complaints like abdominal pain, diarrhea, which can suggest salmonella infection, leptospirosis, tularemia, intra-abdominal abscess, or IBD. Then we have to ask about if there is any limb or bone pain, which can suggest leukemia, lymphoma, brucellosis, osteomyelitis, or septic arthritis. And then ask if the patient have cough or pleuritic chest pain, which can suggest pneumonia or TB. And ask about neck swelling, which can suggest lymphoma. Okay. Next, we have to ask about the exposure of the patient, which is the history of exposure to wild or domestic animals that can suggest that patient can have leptospirosis if the patient is exposed to rats, as example, or Toxocara canis if the patient is exposed to dog, or toxoplasmosis if the patient is exposed to cat. And then we have to ask about the consumption of raw meat, which can suggest tularemia or brucellosis. And consumption of raw shellfish can suggest hepatitis A. History of tick bite or travel to tick or parasite infested areas that can suggest Rocky Mountain Spotted Fever, which is a tick-borne disease, and tularemia or Lyme disease. And then ask about the history of pica. Specifically, ask the mother if the patient tend to eat dirt, because the dog and cats tend to defecate in the soil, and when the patient eat the dirt, it can expose the patient to get Toxocara canis, which is a zoonotic infection by dogs, or toxoplasmosis. And so ask about the history of blood transfusion for hepatitis, and also recent surgical procedure, dental work, tattooing, body piercing, or sexual activity, which can increase the patient to get hepatitis, HIV, or syphilis. And then ask about the drug history. Ask whether the patient has take any drug preparation which is not prescribed by the doctor, as well as the if the patient take any eye drop, because the eye drop can have atropine and can lead to atropine-induced fever. So atropine is a substance is an anticholinergic drug, and it can cause fever by reduce the ability of the body to lose heat by the suppression of the sweat gland, and also increase the peripheral muscle activity, which can also increase the temperature of the patient. And then ask if the patient do any immunosuppressive therapy, because in immunosuppressive patient, the patient tend to get infection. and recent drugs taken because such as penicillin or cephalosporin, because new drugs taken can cause drug-induced fever. And in drug-induced fever, the fever tend to stop after we stop the drugs. Okay, next we ask about the past medical or pathologic history. History of unusual, severe or chronic infection. We suggest immunodeficiency, about malignancy, abdominal surgery, which increase the risk of the patient to get intra-abdominal abscess, tracheostomy tubes or implantable device, which can increase the risk of the patient to get infection at the tube itself or the implantable devices. Let's ask about the family history. However, these types of disease are rare in Malaysia. And the other history that we can ask is about the malignancy. Because in familial Mediterranean fever, which usually occur in Mediterranean area, it is autosomal recessive. So the patient, it is genetic. So we have to ask about the family history of Mediterranean fever. And ask about the travel history. If there is any travel history of traveling to endemic area, such as the area which have endemic with case of malaria, TB, typhoid fever, histoplasmosis. And then ask about the prophylactic immunization, like meningococcal vaccine before the patient went to travel, and also history of ingestion of contaminated water or food during the traveling. And so rocks dead artifacts brought home after travel, because these things can be a vector for the infection. And ask about the exposure to other person with recent history of traveling. And then for the social history, we have to ask about the impact of the fever on the child's health, because it is a prolonged fever, and also the child's activity. And we also have to ask about the parents or caretaker's job, because the Munchausen syndrome by proxy or infectious disorder, it tend to occur in when the patient have parents who is healthcare worker. And then for physical examination, we have to look for sweating and lymphadenopathy, which can suggest lymphoma or TB. And then look at the vital sign, temperature, to know whether the patient is having fever or not. And then look at the pharynx to look for hyperemia with or without exudate, which suggests patient to have streptococcal infection, EBV infection, CMV infection, toxoplasmosis, salmonella, tularemia, Kawasaki disease, or leptospirosis. So for the skin examination, there are some rashes that we have to recognize in a patient with fever of unknown origin. The first one is the palpable purpurate lesion in polyarthritis nodosa. So polyarthritis nodosa is a systemic necrotizing vasculitis that typically affect the medium size muscular arthritis. And also look for the malar rash, which can suggest SLE. And also erythema nodosum, which can suggest IBD or SLE. Erythema nodosum is skin inflammation located at the fatty layer of the skin, usually at the anterior part of the leg, below the knee, and it is reddish, painful, tender lump. And then we look for the Rocky Mountain spotted fever rash. It is described as blanching erythematous rash with macules that become petechial over time. And usually the rash in Rocky Mountain spotted fever started at the wrist and also ankle. And when the rash occur at the palms, also it is highly suggestive of Rocky Mountain spotted fever rash. This is the typical population on the finger of a child with cat scratch disease. So the population occur at the site of the inoculation, at the site where there is the cat scratch. This is the tularemia scar, which is the dead skin. and the classic bull's eyes, as Hazirah has mentioned before. Classic bull's eyes is erythema migrans lesion. Erythema migrans is a flat or slightly raised erythematous lesion that appear at the side of the tick bud. The name migrans may suggest that the erythema migrans is expanding in size. So the size of the erythema migrans tend to enlarge over time. The last one is the rose spot of typhoid fever. The rose spot is small spot, erythematous, blanchable, non-tender papules, which begin early in the during the acute fever period of typhoid fever. So other physical examination we can do is ophthalmic examination, the eye for red weeping eyes, which suggests polyarthritis nodosa. And conjunctivitis is divided into two, whether it is palpebral or bulbar. If there is palpebral conjunctivitis, suggests measles, TB, infectious mononucleosis, or Rickettsial disease. For bulbar conjunctivitis, suggests Kawasaki disease or leptospirosis. And if there is petechial hemorrhage, it suggests infective endocarditis. If there is uveitis, suggests GIA, SLE, Kawasaki disease, and vasculitis. For retinitis, it suggests CMV infection, toxoplasmosis, and syphilis. And if there is any proptosis, it suggests orbital tumor or thyrotoxicosis. For the pupillary constriction, it suggests hypothalamic dysfunction. So these are the picture of some lesion at the eye that we can see in fever of unknown origin. So this is the bulbar conjunctivitis, which we can see in Kawasaki disease or leptospirosis. And this is the palpebral conjunctivitis, in which we can see in measles, TB, or infectious mononucleosis. This is the conjunctival hemorrhage, we can see in infective endocarditis. This is chororetinitis in cytomegalovirus infection. And this is uveitis, which we can see in autoimmune disease, SLE, and also GIA. The physical examination we can do is neurological examination. We look for hyperactive tip and the reflex, which indicate thyrotoxicosis. For the musculoskeletal examination, we look for point tenderness, which can suggest coccal osteomyelitis, because the patient did not present with pain at the bone, but when we palpate at the bone, the patient can feel the pain. Or bone marrow invasion from neoplastic disease. Look for trapezius muscle tenderness, which suggests subdiaphragmatic abscess, and also generalized muscle tenderness, which suggests systemic disease such as dermatomyositis, polyarthritis nodosa, or Kawasaki disease. Other examination that we can do is ophthalmoscope, but we do the ophthalmoscope not in the, at the eye, but we do the ophthalmoscope at the near fold capillary to look for the abnormalities. I will show the picture after this. Because when we can see abnormalities at the near fold capillary using the ophthalmoscope, it suggests connective tissue disease such as juvenile dermatomyositis or systemic scleroderma. So this is the picture. This is the normal near fold capillary loops that we can see through the ophthalmoscope in normal patient. And the below one is the near fold capillary in patient who have a connective tissue disease. With dilated capillary loop and also avascular, presence of avascular area. For the parietal examination, we can look for the perirectal lymph adenopathy or tenderness, which can suggest deep pelvic abscess, iliac adenitis, or pelvic osteomyelitis. These are other physical examination that can do in patient with fever of unknown origin. For investigation, we do basic investigation like full blood count, because when there is increase of the polymorphonuclear leukocyte more than 10,000, or if there is increase of non-segmented polymorphonuclear leukocyte, which is the eosinophil and basophil, more than 500 per microliter, it suggests severe bacterial infection. And we do ESR and CRP. And if there is increase of ESR more than 50 mm per hour, it suggests inflammation, and do liver function test to look for any liver derangement which can occur in hepatitis. Do blood culture and sensitivity to look for bacteremia which can occur in any bacterial infection such as infective endocarditis or osteomyelitis. And then if there is polymicrobial bacteremia, it can suggest factitious disorder because the patient himself or the patient caretaker can inoculate the microbiome into the patient. So there will be polymicrobial bacteremia. The fifth one is urinalysis to look for hematuria and proteinuria, which can suggest SLE, infective endocarditis, or leptospirosis. Urine culture and sensitivity to look for UTI. Chest X-ray to look for pneumonia or TB. There are additional investigation that we can do in patient with fever of unknown origin, which is tuberculin skin test or mantle test to suggest TB. Serological test like anti-nuclear antibody test for SLE, rheumatoid factor for rheumatoid factor positive juvenile idiopathic arthritis, serum complement for SLE, HIV rapid test, EBV, CMV, and toxoplasmosis serology. And then do lumbar puncture to look for the CFS analysis, which can suggest meningitis. And then do bone marrow biopsy and culture to which in order to diagnose leukemia, metastatic neoplasm, or any infection of the bone. For imaging, you can do echocardiogram for infective endocarditis, abdominal ultrasound to look for intra-abdominal abscess, and then do CT scan or MRI of the chest, abdomen, and hip to look for neoplasm and abscess. And you can do MRI to look for osteomyelitis or myositis. And the last one is radionuclide scan when we want to look for abdominal abscess or osteomyelitis. So the management of fever of unknown origin is based on the underlying diagnosis, based on the history, physical examination, and also investigation that we had done. And then in fever of unknown origin, antimicrobial agents should not be used as antipyretics. And empirical trials of medication should generally be avoided, meaning that we can't simply give empirical antibiotics to patients with fever of unknown origin. We have to recognize the diagnosis first before we give the antibiotics. And then this patient, we also need to give supportive treatments like antipyretics. So for the prognosis, in child with fever of unknown origin, it has a good prognosis because as I mentioned before this, usually a fever of unknown origin in child, it is an atypical presentation of a common childhood illness. So in many cases, no diagnosis can be established and fever usually stops spontaneously. And 25% of patients whom fever is persists, the cause of the fever remains unclear even after thorough evaluation. So these are my references. Thank you. Do you have any questions?
Okay. Good. Overall, I think I'm impressed with your new presentation. It's quite detailed. Dengar kan?
Dengar.
It's quite detailed and up to date. Apparently, I never heard about the capilloscopy. But it's got something new lah. So any questions to presenter? Because this you will definitely meet patient with PUO in your life, in your career. You're definitely going to meet patient with PUO, pediatric or adult, like semua akan ada lah. So any questions on PUO? Okay, in general, PUO in general, most of the time is infectious in origin. Second most common is neoplasm, and then third is autoimmune. No, actually second is autoimmune, third is neoplasm. Is the other way around. And then, so first you have to check for infectious, because this is the easiest to treat, okay, compared to other chronic diseases like autoimmune or malignancy. Infectious, being in Malaysia, the top in your list is always TB. Okay, TB is always at the top of your list. And being in Pahang, the second top will be melioidosis. Okay. And being in Pantai Timur, the third top, it will be your typhoid lah. So this is the three top most common infection. You've mentioned about toxoplasmosis, CMV. Actually, most people adopt after neonatal period. To be honest, if you check your antibody titer for toxo and CMV, I would bet at least 70 to 80% of us had toxo and CMV in the past. Okay, that's why it's very common in neonates. If you neonate who born with symmetrical SGA, if you check serology for toxo and CMV, most of them will be positive because they've got IgG from the mother. Especially with our current, I don't know whether this is good or personally, I don't think this is good. Habit of rearing cats. Like now it's become habit and more rather cat. And then everyone eating Western food, the the raw or semi cooked steak kan. So these are risk of toxo lah. But usually toxo and CMV are asymptomatic. You may get low grade fever, very mild symptoms. So I don't think toxo and CMV cause prolonged fever. But you have to put it in the back of your head lah. But the most common is TB, melioidosis, especially melioidosis, those yang presented with seminated abscess. And melioidosis is very common in Pahang. I think Pahang is the most common among all the states. Pahang is the most common incident of melioidosis. Even the CPG on melioidosis is actually produced in Pahang. Okay, and then third is typhoid, which you don't see typhoid elsewhere in Malaysia except in Pantai Timur. Okay, and then your other than infectious, okay, and the other thing is common infection may present with PUO in patient with underlying immunodeficiency. It can be either primary or secondary immunodeficiency. Especially in pediatric, what good about pediatric is there's a lot of genetic disease and there's a lot of genetic disease that present during pediatric. Not many genetic diseases actually present in adulthood. Mostly present in pediatric. So you won't see PID in adult. You rarely see PID in the primary immunodeficiency. You only see primary immunodeficiency and genetic condition in pediatric. So your differential will be massive. Okay, compared to adult, differential of PUO in pediatric is massive. Again, you should use the systematic way, the vitamin A, B, C, D, so that you won't miss any lah. For example, PID, patient with primary immunodeficiency kan, yang common PID macam Wiskott Aldrich, SCID, CVID, chronic granulosis disease, all this, they can present even with simple infection, typical infections such as strep pneumonia, they can present with prolonged fever. But usually, patient with immunodeficient, they don't present with high grade fever because they don't have the ability to induce immune response. Okay, you've mentioned I think in one of your first slides, you show you mentioned about the pathophysiology of fever kan. It can be yang awal-awal yang ada 3 no. Yeah. Mechanism. Pyrogens kan. Pyrogens can be ni lah, all the toxin, immune response, and then heat production, acidic heat loss. Okay, yang ni metabolism. Sometimes things like malignant hyperthermia is quite rare, but it's very important. This is malignant hyperthermia. It's a genetic problem. It's a genetic problem. You won't know until you've been induced. Okay, a lot of people they don't know they have malignant hyperthermia until they went for operation kan. When for operation, induce GA, given midazolam, and then suddenly temperature 41, 42, and then heated. So this is how they presented lah, malignant hyperthermia is a genetic condition. And then ED, I've got family with ED, ectodermal dysplasia, they also presented with me because of defective heat loss. So the pyrogens, so for pyrogens, you need a good immune response to respond with to the pyrogens and produce fever. So patient with immunodeficiency, they rarely have high grade fever, but they do have chronic fever. HIV, of course, kalau HIV nowadays is rare because Malaysia has been declared free of vertical transmission HIV. Because our rate of vertical transmission is less than 1% now. But if you go to ID clinic, you'll meet hold on Sekejap. Okay. I think that's all. Ada soalan ke? Oh, so cat stretch. Cat stretch is salah satu yang quite common dekat Malaysia ni. So Cornelia buneti lah, the organism. Most of these organism, actually some of these organism can be diagnosed by serology lah or PCR. Tapi may not be available in most center. Okay, anything else? Lagi satu cancer, you need to always think of cancer, especially hematological malignancy. Tu cukup, rasanya tu cukup. Okay, ada soalan? Semua mesti dah penat dah. Saya pun dah penat. Okay, last questions before we end. Okay, tak ada. And lastly, before we end, okay, remember fever is not always bad. Okay, fever is not always bad. Okay, we don't treat fever, we treat the underlying causes. Okay, except for some patient, for example like ectodermal dysplasia, the defective heat loss, malignant hyperthermia, this is bad lah, fever bad. But the rest, fever is important for you to induce your immune response. Okay, it's increase your metabolism and prepare your body against infection lah. Okay, I think that's all lah. Okay, thank you. Dia boleh tanggung atas speaker.
Thank you.
Okay.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Yeah.